We're up, right? We're up and live, right? Yeah, we are. Thumbs up.
We're still having trouble with the microphone.
Hey, Facebook. How are you?
Good afternoon. Welcome once again to GBMC Facebook Live. I'm Don Scott with
Mary Beth Marsden, and this is Greater Living, where we're all trying to live greater lives, right?
We certainly are.
A little bit healthier, a little bit better.
And today we're talking a lot about diabetes and weight loss.
Right. Weight management and all that kind of stuff, which a lot of us think about a lot, maybe too much, but...
I'm sorry I got the end seat here because I'm trying to get my... trying not to show my weight problems. Yes.
Yeah, so just before we talk with Dr. Horowitz, which will be right with you, we're going to be here live at 1 o'clock the second Wednesday of every month talking about a new topic that affects a lot of people. And today's just happens to be one that affects millions of people, which is, of course, diabetes and weight management.
And we just followed a half hour where we were talking about diabetes from a different angle, but foods and things like that. So we're going to get a little more technical now, I believe.
Yeah, and get an overview, too, because a lot of you are just joining us for the first time. And, you know, the beautiful thing about Facebook Live, of course, right, and we were talking about how sometimes we know a lot about social media, and sometimes we don't know anything about social media. But I know you know this, and that is people can ask questions on Facebook, and so it's really interactive, and that's a beautiful thing. And for the first time
ever,
for our shows ever, we have a studio audience. Hi, studio audience! Woo! So that's really cool too, and we'll have questions from them. But should we get right to it?
I think we should. Our first guest is Dr. Ruth Horowitz, who is the chief for the Division of Endocrinology, I practice that word, and Metabolism at GBMC, also a partner with Bay West Endocrinology Associates.
Right.
Thank you, Dr. Horowitz.
Thank you for having me. I appreciate it.
So we did have some guests earlier in the last half hour talking about sort of an overview of diabetes, but I think for anyone who's just joining us for this particular hour segment, it is worth repeating because I think people still to this day get confused between type 1, type 2, pre-diabetic.
Right.
You know, what does it all mean and how do you differentiate?
So diabetes is a condition, and everybody can hear me, I assume. Diabetes is a condition where your body doesn't metabolize glucose properly. So your body produces glucose, you eat glucose, and a normal person will deliver that glucose into your cells. A diabetic does not deliver the glucose into the cells, and the glucose is the fuel for your cells, sort of like the gasoline for your car. So there are several different flavors of diabetes. Type 1 diabetes we generally see in younger people, but you can also see it in adolescents and young adults, and sometimes even older patients.
Is this what's known as juvenile diabetes?
Yes, although that's not a phrase that's used anymore.
It's not. That's old school. Okay.
Yeah, they've updated the terminology, and type 1 diabetes is the terminology for this type of autoimmune diabetes, where your body has attacked your own pancreas and you're not making an adequate amount of insulin, so you need insulin as a way to get that glucose into the cell.
For the rest of your life, right?
For the rest of your life.
Yes.
So it is for the rest of your life. You don't outgrow it.
You can't outgrow type 1 diabetes. That's a permanent condition. Type 2 diabetes generally happens, it's more common. It happens with a genetic predisposition. It's associated with individuals who are overweight. And often these patients make a lot of insulin, but the insulin doesn't work very well, and you're resistant to the insulin, so your blood sugars remain high. These patients often can be managed with a variety of medications, oral medication, injectable medicine, or insulin. And things like dietary changes, exercise, weight loss can improve your glucose metabolism, improve your sensitivity to insulin, and improve your diabetes.
I'm always interested in entomology, another big word, but why do they call it diabetes? What does diabetes mean? Is that a question out of left field?
No,
okay.
It's got to be Latin or Greek.
Yeah.
Sure.
Right?
All right.
Actually, you asked me something I can't go.
I meant to look it up before I got here. But
all right, so we'll go somewhere and we know you can go, and that is what are the symptoms of one or both?
Sure. So both type 1 and type 2 diabetes will present very similarly.
Okay.
Because you can't absorb your glucose, it rises in your bloodstream, and when you have very high glucose level, it provokes a thirst mechanism, very similar to if you eat a high salt food, makes you thirsty. Your brain senses that high glucose level. So you become very thirsty, you drink more water because you're more thirsty. Unfortunately, a lot of people, when they're not diagnosed, drink a lot of other things like juices and other high sweet things and make their blood sugar higher. But you're thirstier, and because you're drinking more, you're also urinating more frequently. The other thing that happens is your body tries to to get rid of the glucose by urinating it out. So you're urinating more frequently because your body's trying to eliminate the sugar, but you're also drinking more and you're peeing more. So it's this cascade of very thirsty, drinking a lot and urinating. And because you're not absorbing your calories, oftentimes you become malnourished. Even though you're eating lots of food, you can't absorb those calories into your system and you lose weight. And you become tired and fatigued. You also can have difficulty with blurred vision because the lens of the eye swells with the high glucose levels, and then it becomes very difficult to focus near and far.
Is there sort of steps to these? I mean, is the first sign the thirst, and then maybe people just think they're thirsty and they just keep going, and then it's not until what's sort of the trigger that gets people to really seek help? Is it the blurred vision?
I think that when people start having blurred vision, and also when they are urinating so frequently that they sort of realize, hey, maybe something's going on. And I think that people are becoming more familiar with those symptoms, and there's so much common diabetes that a family member may say, hey, you're having typical symptoms. Here's my meter. You need to check your blood sugar. So oftentimes it's someone else who's alerting the person.
Or a parent to a child, right?
Exactly.
But if, let's say you don't go to the doctor a lot, and you got these symptoms where you're thirsty, but you drink a lot of water or something. Do most people find out by symptoms, or do they find out by blood work being done?
It can be found out either way. Many people present to their physician with symptoms, but unfortunately, physicians often pick it up incidentally, that they're doing routine screening tests, and the patient just sort of thought, well, I was sweating more, so I just drank more, and they sort of don't know those symptoms, so they don't recognize it, and it's their astute physician who says, when they come in thinking something else is wrong, oh, you have typical signs of diabetes, that's what's going on. So you can see it in both flavors.
But in the blood work, it shows up as my sugar levels, I hear people talk about?
So when you're doing blood work, one of the typical labs that you do just on a patient for routine health maintenance includes a blood chemistry level. There are some specialized tests that we can do to look at diabetes, and one test that's frequently done is called a hemoglobin A1C. And that's a test of measuring how much glucose is bound to your red cells. And once that glucose binds to the red cell, it doesn't go away until the red cells die. And so your A1C reflects an average of what your last 3 months of sugars were circulating in your bloodstream, and you can measure that level, and there's a normal range. So a normal hemoglobin A1C is 5.6% or below. And if you're in that 5.7 to 6.4 range, that's called prediabetes. And when you're getting over 6.5, that's diabetes. So your doctor can measure this hemoglobin A1C test, and that'll give you an idea of where you are in the spectrum of whether your glucoses have been normal over the last several months or whether you're already starting to develop a problem.
So prediabetes is definitely probably the wake-up call.
Absolutely.
For a lot of people who, I've heard a lot of people say that they're pre-diabetic.
Yes.
And is this the one condition, let's just say, that you can reverse or slow or stop?
Yes, you definitely.
By being pre?
Absolutely. And even with prediabetes, even with type 2, if you are really making some dramatic changes in your lifestyle, in your eating habit, in your weight management, you can shift yourself back into the prediabetes range. With pre-diabetic patients, this is the warning sign where patients really can take that moment to look at their lifestyle, to look at their eating habits, to look at their exercise, and improve their glucose control back down into the normal range. It also, unfortunately, is a point where a lot of people don't take it that seriously, and left untreated, a pre-diabetic patient can very commonly become a diabetic patient. And the health risks increase as your glucoses become more abnormal.
I know when people hear that they have diabetes, type 1 or type 2 or whatever, immediately I think of having to inject themselves several times a day with insulin. Is that still the main treatment?
No, well,
Wearing
it is.
a pump or
there are lots and lots of medications now for the treatment of diabetes, and for the most part, people are started on oral medication unless they're a type 1 diabetic where insulin is the therapy. For a type 2 diabetic, the availability of medications has become amazing. And when I started practicing, which unfortunately was longer than I want to say how long ago, we had...
That's a good thing you're wise.
Yes. We had 1 or 2 pills and insulin. And now there is a whole host of medications that one can be given, and we often layer medications on top of each other because they all work in different ways to improve the glucose level.
And I would imagine they're more tailored now for the individual.
Right.
Right.
So that there are certain drugs that you might not use if they have other concomitant medical problems, medicines, but there are oral medication, there are injectable medicines that are not insulin that will improve glucose level, and there's insulin, and there are oral insulin, inhaled insulin now for short-acting insulin, yes, as well as injectable insulin, and you can also have new delivery methods of giving the insulin. So other than inhaled, you can inject, you can do it with a syringe, you can do it with a pen, and then there is an insulin pump, which uses all short-acting insulin, but in a continuous infusion. So the person wears a device that has a small little catheter that goes under the skin and delivers continuous insulin, and then you can program the pump to give you meal coverage when you need it.
So like a really active kid, an athlete.
You know, we are
Often.
seeing more and more people using insulin pumps of all type. It used to just be all type 1 diabetics. We are using it in our type 2 diabetics. We're using it in the elderly. We're using it in the young. It is becoming commonplace. Recently, Medicare approved the use of insulin pumps and glucose sensors, which was an astronomical change for Medicare patients. Did not have the coverage to be able to use the most sophisticated device, and now the government is now covering these devices for all of our patients. So it's just extraordinary what our choices are to improve glucose control.
Speaking of choices, I know several diabetics who always complain about having to prick their finger for their tests. After all these years in modern medicine, isn't there a
Is
better
there something
way?
better? I kind of wish there were. I really wish. You can do your glucose testing on your finger. Many meters allow you to do what's called alternative site testing, which is on the forearm. But you still have to prick and get a blood sample. Some patients can wear what's called a continuous glucose sensor, which is this device that has a catheter that actually sits under the skin and will measure continuously your glucose, and then it's read out on either a pump device or on a handheld device. Some of them actually can coordinate with your phone for iPhones.
A telephone app, sure.
Yep. And so it gives a continuous read. You still have to calibrate those devices with a glucose several times a day, but the newest sensors are so sophisticated and accurate that you can look at the device and say, oh, my blood sugar is 125, and I can dose my insulin based on that. So if you are on insulin. So there are ways, but these devices are expensive, and they require a certain amount of training and knowledge to use them effectively. So finger sticking is sort of the mainstay of therapy right now.
Both of that and the insulin pump sound like it would be only for extreme cases.
No,
The pump is used by a lot of
we
kids
use it in a
and-
lot of people. You do. Unfortunately, patients think that they can just slap the pump on and walk away and it takes care of everything. And that's not the case. Patients can have lousy control on an insulin pump if they don't manage it properly. It still requires you to be involved, to know what you're eating, to know how to count your carbohydrates, to troubleshoot when the pump is not working properly. So you have to still be very involved with the pump. There is a newest generation of pump that actually integrates a sensor and a pump and actually can adjust the pump delivery based on an algorithm that's continuously reading your glucose level. This is called the closed loop pump, and this is becoming an amazing tool for patients so that the pump actually thinks and changes the amount of insulin that you're being delivered on a continuous basis. And these devices are amazing, but they still require a fair amount of attention and knowledge. And we've trained all sorts of different patients.
Which is why it's so hard for parents of young kids because they're too young to really manage it on their own, or you're trying to teach them, right,
Exactly.
as soon as possible. But
I think a question that has to be asked, is it covered by insurance?
Yes.
Okay.
For many insurances,
Okay.
it is. I mean, for children, what's very nice with some of the devices is that a parent can actually have a sensor for their child beamed to the parent's phone.
Okay.
So
Yeah.
a parent can be off-site and know what their
find my
their
iPhone,
blood sugars
find
are.
my insulin pump. Right?
Yeah. I've had spouses do it, where a husband has low sugars and the wife carries the information on her, so she can go to work and not worry about her husband,
Right.
and then call him if he's having trouble. I have a patient who is definitely doing that.
We are getting a lot of questions, and we want to get to them, but I wanted to ask you, too, about screening, and I didn't know where you stood on that.
There are definite guidelines of who should be screened.
What do you feel about it?
Well, Well, there are various guidelines by the American Diabetes Association and the U.S. Task Force, and patients over the age of 45 should be screened for diabetes every 3 years. If you have a family history or other risk factors, gestational diabetes, if you're overweight, some guidelines include hypertension and high cholesterol should be screened more frequently and absolutely every 3 years in those higher risk patients. So it is something that we should be screening for because it's unfortunately way too common and often undiagnosed.
Right.
And if we can diagnose it sooner, we can prevent many of the terrible complications that come from diabetes.
Yeah, can't let it go.
Questions online? I saw
We
you.
do. Mindy has texted me, and do you want to just read them out? Great.
I've got one here from someone in our live audience. What should a diabetic do when they are having symptoms of hypoglycemia, such as faintness, shaky, being sweaty, and irritable?
That's a great question. So those are the typical symptoms of hypoglycemia, although sometimes you can feel kind of lousy and think your sugar is low, and it's important to check your glucose before you treat it because sometimes you're actually high and you feel lousy. And sometimes symptoms don't always correlate. But let's say you know you definitely have a low blood sugar. We start with 15 grams of carbohydrate, which, if the people remember from the previous talk, is the quickest acting thing is something like juice. 4 ounces of juice is a good way to start. Drink that down, wait at least 15 minutes and recheck your blood sugar and see if it's starting to respond 15 to 20 minutes. And then if not, you can repeat another 15 grams of carb. You know, if you're close to a mealtime, you want to go ahead and eat your meal. A lot of times people get low because they've put off getting to their food. So eat. Eat something a little more substantial. If you think that you've taken a dose of medication that's going to be lasting for a long time, or perhaps you did some extreme exercise that's going to keep on lowering your blood sugar, eat something a little bit more substantial, half a sandwich, you know, if you're seeing that your blood sugars are not coming back up.
Other questions?
Miller?
We do have another question. This one's coming from Facebook, and it'll probably be our last question with Dr. Horowitz. We're going to move on to our next guest pretty soon. This question is from Anthony, and he says, I've heard that peanut butter is a good source to have nearby if you're diabetic and your blood sugar drops. Is that true?
Peanut butter could work. That may take a little bit longer because it's got some sugars, it has some protein and fat, so that might be something to follow up with something more rapid acting, like the juice. Some people do things like glucose tablets, some people do icing, which I personally didn't think that would sound all that great, but that's a more rapid acting. The peanut butter would be a great choice because it has some of the extra stuff that will carry you a little bit further after you've done that first 15 grams of carb.
And I guess it's quote unquote better for you
than icing.
Something
Yeah.
sugary, but you want something so liquid really when it comes right down to it. It's going to be the
something you don't have to
acting.
digest.
Right.
You know, that'll get into your system a little quicker.
Right.
All right. Thank you very much, Dr. Horowitz. We're going to bring up
The time was fleeting.
It was very quick. Thank you very much for having me.
Thank you
Thank
so
you.
much.
Sure.
A wealth of information, and we have more to come.